I'm Dr. K.K. Agarwal, President Heart Care Foundation of India. Let's go back to our subject. Our guest today is, we have with us Dr. Vishal Kaura Agarwal at B.L. Kapoor Hospital and Max Smart Hospital in the city of Delhi. She did her MBBS from Patiala Medical College. She did her MD in medicine from Amritsar. Then she did fellowship in rheumatology at Indian Spinal Injury Center and super specialty from Royal College of Physicians in London. So we, of course, when we are talking to a rheumatologist, we'll talk about basic rheumatologists. Vishal, my first question is that when there was a term called rheumatology department, it has been renamed. What is the new name? Something related to musculoskeletal.
Musculoskeletal medicine.
Musculoskeletal medicine. How is it different from orthopedics?
Orthopedics.
Because that is also musculo, that is also skeletal. They also do bone, they also do muscle surgery, they also do muscle tumors.
Exactly. So rheumatology is a branch of medicine. So it's a super specialty of medicine which deals with the musculoskeletal diseases and autoimmune diseases. Rather systemic autoimmune diseases which have some musculoskeletal manifestations. So rheumatologist is an internist who is taken more training in dealing with autoimmune diseases.
So if I have to go back to, so from a GP perspective, or from a common man perspective, if I have to find out some basic tips from a distance, that say for example, we say after the age of 40, first attack of acidity is heart attack.
Okay.
After the age of 40, first attack of asthma is heart attack. So we have some signals for that recently. So similarly in musculoskeletal systemic diseases, whether autoimmune or not, are there some markers? Can we identify 4, 5 or 6 markers for people from a GP from that he knows, oh, I'm missing something. Why I'm talking about it? Because this was not taught to people like us in great detail. That probably rheumatology was, musculoskeletal department was not there, all were internists. So therefore we ended up in learning later after passing our MBBS. Do we find any?
So for musculoskeletal diseases, I would say if any musculoskeletal problem related to joint, bone, muscles, ligaments is persistent, then we should approach a rheumatologist. But the most important thing are the inflammatory diseases which need to be recognized and handled as early as possible. So the markers which you asked me would be for, let us say for an inflammatory disease, a back pain. In a young boy, there is inflammatory back pain, which comes up, which is maximum at night or early in the morning with prolonged stiffness, but on walking about and exercising, it improves. So rest worsens it and exercise improves it. This is one indication that it can be an inflammatory disease.
So if I take one marker is that any stiffness, any joint in the body,
prolonged stiffness,
any joint in the body, and if you find that it worsens on rest, improves on exercise,
it indicates some inflammation.
It's an emergency.
It is.
It cannot be ignored.
It cannot be ignored. So it indicates inflammatory
so that is one. So in terms of a joint or a musculoskeletal system, anything, if you are disturbed with anything which worsens on rest, because supposed to be, normally what happens is fracture. If you get fracture, if you get trauma, the answer is rest.
Yeah.
The answer is rest. Here rest is the enemy. Therefore, if rest is the enemy, it's a medical legal emergency.
Exactly. The patient does not want to rest, doesn't want to lie down. He says walking about helps. So he prefers walking about or moving about.
So unlike chikungunya where rest helps.
Yeah.
So chikungunya is not it is also a musculoskeletal, but it is not inflammatory.
It's an acute viral induced inflammatory.
So another thing is that say for example now in chikungunya we say fever with skin and joint involvement is chikungunya, but without fever, if the skin, joint, kidney, if any two are present, it's not immune.
Yeah. So no, fever is of course a marker that.
Let's say no fever. If a person has a skin, joint, and kidney, so there is the involvement of skin, some rash or something. There is some involvement of joint and some involvement of kidney. It's not immune.
It is an autoimmune. It may be viral induced even, like hepatitis B, C, but it is autoimmune.
It's an autoimmune. All types of autoimmunes. Even chikungunya is an autoimmune.
Yeah.
Because chikungunya is a viral induced and therefore steroids are given to that. So skin, joint, kidney. So if I have to tell my GP, he has to remember two things. Skin, joint, kidney, two things, send it to rheumatologist. Or if he finds that he has
any joint
swollen
and mobility is also, if he finds any joint red, swollen and difficult to move, and
then he will go to another orthopedician. He won't come to you. So therefore let the orthopedician send it to you. But I cannot tell that with a swollen joint, don't go to orthopedician.
No, there are, if there's oligoarthritis, if we find three
single joint involvement, I would like to send it to an orthopedician.
Or maybe a medicine person, it's
but
an emergency.
If it is 2 to 5 joint involvement, multiple joint involvement, yes, it may be a systemic disease.
Right.
But if it is linking it to a systemic disease, then it is not a surgical problem.
It is not. It's
so if there is a fever, if there is a systemic manifestation, lethargy, not feeling well, then probably he's suffering from a medical illness.
Exactly.
Medical illness, it has to go to a particular
physician, to a
physician with that. So therefore, I have divided your complete musculoskeletal system and autoimmune disorders into a systemic disease. So
systemic autoimmune disease.
So no, I am not using the word autoimmune.
Okay.
Systemic disease, anything related to muscle and joint which looks like systemic, or there is a skin, joint, kidney, or it improves on exercise, then they need to be shown to
a rheumatologist.
A good physician who understands rheumatology or to a rheumatologist.
Right. Good.
Because I can't say that.
Yeah, physicians, they understand. Rather, orthopedicians also in our hospitals, they understand that this is not my area. So directly the patient comes to the rheumatologist.
So when it comes to joint, we have different terminologies and different diseases. Okay. I'm not going into monoarthritis, oligo or polyarthritis, because that most of people understand with that. So I'll straight away come back to when we talk about, say, a few conditions. One is rheumatoid arthritis. Okay. Now we call them as inflammatory polyarthritis or rheumatoid. I call it as a Dimak Lagna versus Jang Lagna. So
that's nice.
That's a word I use to the patients.
We call it a storm inside.
No, जंग लगना दिमक लगना सबको समझता है. जंग लग गया है कोई बात नहीं. दिमक लग गई है like emergency.
Yeah.
It is destructive. Okay, with that. And then we come back to, we used to call a condition called Ankylosing Spondylitis, bamboo spine. Terminology.
Now the term is spondyloarthritis.
Spondyloarthritis, yes. And now we call them as inflammatory spinal arthropathy.
If it is related to only spine but peripheral joint, then it is inflammatory polyarthritis.
Polyarthritis, and then you have a inflammatory polyarthritis peripheral joint.
Yeah, that is, we call it
undifferentiated. It's a mix of them. So just try to differentiate them a little bit more detail. First of all, rheumatoid.
Right. That is the commonest arthritis we find, and here in India we find it's almost 7.75 to 1% prevalence is there.
No, it's young female.
And young, and so, of course peak is in the fourth to sixth decade.
So 40 to 60 years.
The peak time.
Okay.
But it increases in prevalence with age.
Okay. Well, I normally see most of them 20 to 40.
Yeah, that is there as a peak. It is there from 20 to 70.
Okay, so young,
incidence
I still say young
age.
To middle-aged women.
2 to 3 is to 1 is the ratio. Female are affected 2 to 3 times more than men. And it is a very heterogeneous disease. Of course, the classical markers, classical presentation is with wrist and small joints of hands, but it can affect, any of the synovial joints. So, if at all a female comes to you with these small joint of hands involvement, laterally symmetrical, the indicator is.
I normally tell my GPs whenever I discuss with them on rheumatoid is that a female will come back, okay? दरवाजा नहीं खुलता इस मोमेंट, ठीक है? आटा नहीं गूंथता,
Caps.
कपड़े नहीं धोए जाते और लोगों से हाथ मिलाते हुए डर लगता है. Because specifically warm shake hand, not warm shake hand where you press.
You press it.
So therefore it will always be painful. So can this be a marker for a GP that absence of this pain rules out moderate to severe rheumatoid arthritis?
Yeah, in the beginning it can.
Similarly, you do it on the leg. You press it, there will be no pain.
Yeah, one screening test what Dr. Malviya taught us, he did it many years back, and when he was doing some studies in the population, that this MCP squeeze.
This is what I'm talking about.
MCP squeeze is one screening test. If you find that this is tender,
no, this is what I like. When we shake hands, see,
exactly.
when we shake hands,
you do the
this
MCP squeeze.
This is MCP squeeze.
Exactly.
And if this is absent, either the disease is controlled or the patient doesn't have a disease.
Yeah, more or less.
Most of them will invariably have a pain here. Similarly, you can compress the tarsals, mid-foot tarsals, and the pain will be there. So this is basically, if it is bilateral, you know you are suffering from a.
It is a very good
screening.
So
this is a very good screening test, and this is a, for a GP, it becomes very effective. Very effective as a screening test. Now, so inflammatory arthritis, when we talk about rheumatoid, in a rheumatoid arthritis, you do a MCP squeeze, you just shake hand and squeeze, and if there is a pain, and the pain is not visible, pain will be visible. Pain will be visible on the face. You don't have to look for it. Just look at the face, and the patient becomes like, he screams like pain. You know you are dealing with the inflammatory metacarpal arthritis, which is rheumatoid arthritis. It's a medical emergency. Now, you diagnose immediately. You say suspected rheumatoid arthritis, and then I have two options: ESR. So I go for I have option of ESR, CRP, platelet count, rheumatoid factor, and anti-CCP antibodies. How do I? So all of them, one of them?
Yeah, we begin with the hemogram and ESR.
So in hemogram, I'll get a platelet count and an ESR.
And TLC may be raised and hemoglobin may be
TLC
low.
may be raised. That will be sign of chronic inflammation. Anemia of chronic inflammation. But if I have a high ESR, that will tell me activity.
Goes in favor of
activity. CRP may be positive, more than 6. So I have to do CRP and not HSCRP.
Yeah, not HSCRP.
And then if I do a rheumatoid factor, it
may be positive, may not be positive.
If it is negative, I'm worried.
Yeah.
So
if it is negative, then
I'm worried.
Then we get.
Then I'm worried. It may be a serious type of a rheumatoid arthritis. So negative.
So we get the next anti-CCP done.
Anti-CCP done.
But if that is negative, then again, then the problem comes. Then it is more of it is seronegative, we say, but seronegative is it can be anything. With time, it can progress to any of the connective tissue diseases. So that needs more, keen.
So therefore, if I get a screening test positive, I'm dealing with the autoimmune disorder. I'm dealing with an autoimmune disorder, whether it is seropositive or seronegative. A seronegative does not mean that the patient is normal. Seronegative is a different categories of. Earlier we used to call them as seronegative arthritis. Now there are different terminologies used. We'll come back to that.
It may be a gentle one.
Now, when I say patient has a now inflammatory polyarthritis or has a rheumatoid arthritis, then I need to decide acute, subacute, or chronic. What is that number?
So, rheumatoid arthritis, when we define it, is chronic, and in our recommendations, it is any pain more than 6 weeks. But with the latest guidelines, we can diagnose one joint with less than 6 week duration. Of course, we need to have acute phase reactants and the antibodies positive. So that would be acute.
So anti-CCP antibodies will be positive at what time?
They can be positive years before the onset of the disease. So that is no criteria, because it has been seen that anti-CCP is positive years before the onset of the disease. And one form of arthritis is palindromic arthritis, in which we find that anti-CCP is very high and the patient has pain, swelling, redness, comes, stays for a couple of days and goes away. And when patient comes to us, there is nothing. But if we take the history well and we find anti-CCP positive, that goes well in favor of palindromic.
So anti-CCP cannot be false positive? Practically.
Practically, when we have a clinical correlation.
So,
of
clinical
course,
correlation.
even tuberculosis can cause anti-CCP positivity. But
Okay, so anti-CCP, if you do a clinical correlation, if you get, that's the most sensitive test, to get it done. Once positive, it will remain positive.
Anti-CCP is more specific. Yeah, it will remain positive.
So it is not like with treatment it will become negative.
No, it may, the levels may go down, but
it is not a marker of activity.
No,
it's a marker of a disease.
Yeah.
It is not a marker. So like ESR, with treatment it will go down.
It will improve.
Now, when I start my treatment, let's quickly talk about in rheumatoid arthritis treatment. The standard treatment is that you give them, first of all, you start with painkillers as a bridge therapy to relieve, and along with that, do we start disease modifying from day one?
Yeah. It is a medical emergency, so we do not want to waste even an hour for that.
So we start with the disease modifying. So we start with methotrexate injectable from day one, weekly, to be given with prednisolone, to be given with bridging of folic acid twice a week.
Yeah, bridging therapy we do is short, maybe 2 to 3 months of steroid therapy.
We can also give 2 to 3 months of steroid therapy. How much?
We give as our, I have learned from Dr. Malviya that we give a very low dose steroid daily, like 5 milligram of prednisolone daily. And one regime was devised by him, which we give as weekly, like 20 milligram
that
of
was used to
Visalon.
be before methotrexate.
Before methotrexate. So it's a very low dose, 5 milligram of Visalon for a month, and then 2.5 milligram.
And this with methotrexate, prednisolone can be taken out after a couple of months.
Yeah.
Then you continue methotrexate.
Exactly.
What about hydroxychloroquine?
Hydroxychloroquine is all the patients we give.
How much time it takes to act?
It's a very slow acting drug, maybe 2 to 3 months its effect starts to begin.
So therefore you can give hydroxychloroquine along with methotrexate. When do you call it as a failure?
As a first line therapy, Folitrex and hydroxychloroquine, and with bridging therapy we give at least 6 months.
6 months. And at 6 months if you find, when do you add Selazoparin, when do you add other?
It is the next, at 5 to 6 months only when we find that.
Not before that. So the first thing you give methotrexate and...
we build up the dose of Folitrex and...
Up to 20-25 milligrams.
25 milligrams.
Okay, and then you can go back to H-sequences 2 tablets per day. Try for 3 to 6 months. 5 to 6 months. If it fails, then you have choices. Now, you have choices about other medicines which you can use.
When there are other DMARDs also, like we have Selazoparin and we have leflunomide also. Of course, we cannot give leflunomide in females with reproductive time, but reproductive age, but others we can add leflunomide.
So there is nothing like leflunomide, there is nothing like Selazoparin. All of us should remember that these two drugs are not available in our armamentarium. So our job is to stick to methotrexate and give them HCQS, and at 6 months, if we find no response, let them deal with it. Let's not take the headache of knowing other DMRTs. That's their job, let them do it. That is, go to a rheumatologist. But up to the level of methotrexate and HCQS, a senior physician, MD physician, and a senior orthopedist, if they want to treat, they should be able to treat. But other drugs, because other drugs are and then subsequently biologics, all this should be managed by a qualified rheumatologist.
But I would like to add that building up the dose of Folitrex and at least one consultation should be done by a rheumatologist, and then of
may
course,
or may not happen. May or may not happen. We don't want to say advisable. It is advisable to consult a rheumatologist, because there will be senior physicians who are practicing rheumatology for a long, and there will be orthopedicians who are practicing rheumatology like services for a long. And if they are confident enough to manage, it's fine. But going back to the second step and third step, I think there should be a limit. They should go back to rheumatology, because we don't have enough rheumatologists in the country to take care of 1% of the population. So therefore, we need to give it to the people. Now, little bit quickly about biologics. They are costly.
Yeah.
Okay. So I only want to say, because adalimumab is now available in the country, which is cheaper, which is subcutaneous.
Every 2 weeks.
Every 2 weeks it can be given, and therefore
there are many of them which have come. Infliximab was there for last many years.
Very costly.
That is still the best, but the most costly. And then there's Etanercept is there. There's Golimumab is there. These are the TNF alpha inhibitors.
Now, if a patient is on TNF blockers, what precautions he needs to take?
First of all, we screen the patient.
We have ruled out tuberculosis, we have
Then
done
it
Hep
is-
B, Hep C, HIV, all are negative.
Then lead a normal life.
Hmm.
But at any point we find that there's any infection, and then we have to take a quick action. That is all we need to, because incidence of tuberculosis is more in patients taking TNF alpha.
Therefore, before we start biology, we always do a
Screen
Montos
them.
test, screen them, and if necessary, we do a gold interferon. That's one condition where still gold interferon is done, otherwise we don't do it. And we look for any marker of underlying tuberculosis which can flare up. Now let's go back from rheumatoid to seronegative arthritis. And there are, just to add, chikungunya epidemic is going on, and chikungunya can precipitate underlying seronegative arthritis. That means if the patient has psoriasis and he doesn't have arthritis, chikungunya is precipitating psoriatic arthritis, other seronegative arthritis. Therefore, in chikungunya, if you find a patient after a month, if his joint pains are still persisting, it can be chikungunya, but it can also be an underlying chronic seronegative arthritis which gets precipitated. So let's go back to the concept of seronegative arthritis, SSA, as we used to call them as long time back, and now we are calling them as inflammatory spinal arthritis. What is that? Or inflammatory polyarthritis, peripheral arthritis, what are these conditions?
And as broadly we say as spondyloarthritis.
Spondyloarthritis.
Because this group of diseases may affect the spine. So it has 5 varieties. One is ankylosing spondylitis, which affects the spine. And of course there may be peripheral involvement also. Then there is reactive arthritis because of the gastrointestinal and urinary infection. The body reacts by showing there is polyarthritis. Then there is psoriatic arthritis related with psoriasis, and then there's IBD, bowel disease related arthritis. And fifth one is undifferentiated arthritis. When we cannot put any arthritis into these categories, then we diagnose that as undifferentiated arthritis.
So let's go back. Psoriatic is common in India. So everybody should remember that, ask the patient if he has arthritis, are you going to a skin doctor or not? They may not tell you. And if you don't want to talk about a skin doctor, always tell them, are you taking some homeopathic treatment? Because most of the psoriatic patients go to a homeopath to get treatment and they won't tell you. And they may be having psoriasis somewhere, they may be able to tell you. So ask them, are you going specifically to a homeopathic doctor? And they may be having an arthritis, a psoriatic arthritis. Inflammatory bowel disease, whether it is ulcerative colitis or Crohn's, you should be able to get. Patient will always be on treatment, will be in active disease, he should be on other treatment also, and you should be able to diagnose with them. In reactive arthropathy, yes, it's a tricky situation. When you have a GI or a UTI, Batchers, Reuters, all used to come into this.
Yeah, Reuters is part of it. There's conjunctivitis and urethritis along with the arthritis.
So
Batchers is that we take as as a different category in vasculitis.
In vasculitis. And then there is an ankylosing spondylitis. That's something I want to devote to a couple of minutes, because I've seen many of my close known to people who have ended up into a complete disability because they did not listen to get treatment in time. So let's spend a couple of minutes in ankylosing. If you suspect ankylosing, a patient invariably will come with peripheral arthritis, with sacroiliitis, spinal involvement with MRI or with X-ray chest. And if you have a spinal sacral iliitis or a sacral involvement with peripheral arthritis in a male, it's a medical legal emergency. Again, these are the people who will have an improved back pain with walking, with exercise. Tell something more about ankylosing.
So ankylosing spondylitis is part of spondyloarthritis, which in the earliest phase affects sacroiliac joint. And initially patient, because it is insidious in onset, the patient gets pain, patient gets buttock pain, gets relieved very quickly with the painkiller, and after a few months again he gets. So this keeps going on, and the patient comes to the physician after years together. And by that time, few of the patients have radiological changes. You get an X-ray done, there are sacroiliac joint changes, and that we call as radiographic, when the sacroiliac joint involvement has reached to a stage, like we say as this, there is a sacroiliac joint ankylosis, that's class 4, that is for sure, that is ankylosing spondylitis, and the stage 3.
In much earlier you can get a B27 done and find out.
B27 is not very important that way. We need to make out, is there sacroiliitis or not. So in those patients, we are not able to make out any radiographic changes over the X-ray. Then we need to go in for MRI. So MRI, if it shows bone edema, if it shows inflammation, then it is sacroiliitis only. And
so if you can diagnose it earlier, you should be able to.
Yeah, it is. The earlier the diagnosis, the better the prognosis.
If a patient we are suspecting inflammatory spinal arthritis, we have the clues are peripheral, male, young.
A male,
stiffness.
Of course, it is almost 3 to 5 times more common in males. But I would like to say that it is very much prevalent in women, and in women it is.
The same thing for rheumatoid. That's predominantly of women.
But it is ignored because females have back pain after pregnancy, but that is ignored.
Okay.
So in women also, if there is we say alternate buttock pain or there's low back pain, which is more of inflammatory, has inflammatory pattern, you need to go to a physician or a rheumatologist first. So rule out any inflammatory arthritis. So for inflammatory arthritis, we would first do an X-ray. If we find any radiological changes over the X-ray, then we don't know.
Testing. Suppose I say MRI,
testing is more of
B27 positive or negative. Next.
B27 is the
CRP will be
CRP and ESR. That indicates inflammatory element.
Any other thing which we can do?
So for those patients which we're not able to make MRI SA joints.
So if there is a sacroiliitis,
in those patients where we are not able to make out at all and one is not able to get an MRI done in poor patients, so an important test is NSAID. If we give NSAID, the patient responds very well. That is also
specifically naproxen,
an indicator of.
So that's a clinical indicator that if you get a joint pain or a spinal pain which specifically responds to naproxen
or
indomethacin,
NSAIDs will
specifically.
Naproxen is a very good anti-inflammatory agent.
And indomethacin.
And the best for spondyloarthritis is of course torticoxib, but we need to see any hypertension.
So if they respond to beautifully to anti-inflammatory NSAIDs, then we know that it is an inflammatory condition.
Yeah.
Okay. Now, if you have a patient with ankylosing spondylitis, what is the line of treatment?
So first line of treatment is NSAIDs only.
Yes, you continue NSAID as a therapy. Not as a painkiller.
No.
So NSAID in ankylosing spondylitis is a DMRD.
Exactly. So it modifies the disease.
It modifies the disease and you can continue it for 2 years.
Yeah, 2 years, and then after that we do as SOS.
And then after that, suppose you find a disease which is actual, not responding to NSAID, before going to biologics, what other options are available?
What happens in very young patients, we try to, add SAS, lazopiral in them. And if that may help, but of course in axial disease, it has been shown that it does not affect more. But in younger patients,
and what about zoledronic acid and other things which we give?
That had shown that, there is some anti-inflammatory action if they're given with the methylprednisolone. But there are studies and almost 50-60% of patients respond to that. But these days we have a variety of biologicals. So on NSAID failure, we go for biologicals.
Lifelong.
Biologicals.
Lifelong.
It is more of, lifelong.
So we do talk about, we have talked about most of the seronegative arthritis with that. And then we come back to now quickly to autoimmune disorders. And we did talk about skin, joint and kidney. Whenever you get a skin rash, you have a joint involvement or a kidney involvement. A kidney involvement in terms of a cast or in terms of a proteinuria. And if you have a cast or a proteinuria or if you have an RBC, we talk about skin, joint and kidney. And whenever two of them are there, we know that it is autoimmune disorders. Let's classify autoimmune disorders, spend some time in autoimmune disorders. And let's also talk about certain factors. There is SLE, scleroderma, undifferentiated, differentiated, different types of autoimmune disorders. Let's have few words.
So in connective tissue diseases, there is a long list, and most common is systemic lupus erythematosus. It could be Sjogren's. There could be which are not very uncommon in our OPDs. And for other diseases affecting skin and kidney, there are vasculitides. There could be small vessel vasculitis, medium vessel vasculitis, or the large vessel vasculitis. And the most important among the small vessel vasculitis, which could be very dangerous, are the anchor-related vasculitis. No, SLE is a multi-system disease. Any patient who comes with the musculoskeletal affection like joint swelling, joint pain, generalized body pain, there may be skin rashes. One most common rash which we find is photosensitive malar rash, or there could be various variety of rashes over the body with hematological involvement. There could be anemia, hemolytic anemia, there could be...
I'm looking for tips. These are all your disorders. I'm looking for tips. So the tips we have learned today is squeezing test. We have tablet, you squeeze, pain, look for rheumatoid arthritis. That's
So
all.
for lupus...
So we have talked about rheumatoid factor, may be positive, may be negative, but CCP antibodies are important. That's a clip. Third clip we have talked about is if you have a heel pain, any pain of joint pain which improves on exercise, don't ignore it. Heel pain, chest pain, unexplained, and a young person, again pains improves on exercise, don't ignore them. Similarly, we need some more tips in Hashimoto's, because Hashimoto's is very common in India as an autoimmune disorder. Think of SLE.
So important thing just to screen if you want to pick up, the features which indicate connective tissue diseases are, of course, skin, joint, Raynaud's. Raynaud's
skin,
is
joint, Raynaud's, yes.
very important to
For
ask.
me, it's a skin.
Yeah, skin, the joint involvement, the swelling and pain, and Raynaud's. We need to ask. And of course, very important is mucosal involvement.
So whenever there is a Raynaud's
Mucosal
mucosal involvement. So skin and mucosa. So I'll say skin and mucosa. In joint, 1, 2, 3 or 4 joint involvement.
It could be one or it could be multiple.
1, 2, 3 or 4.
Yeah.
Poly, yes, but then poly you will start thinking of other things also. And then there will be a Raynaud's phenomena, unilateral or bilateral. Of course, if it is unilateral, you also start looking for a local disorder. And then there is a mucosal involvement. And if their urine shows a pus cell or a cast, get concerned if the urine shows RBC cast or a pus cells or albumin, proteinuria, get concerned with that. Now, in thyroid, because we get a lot of thyroiditis, I see a lot of, I don't know how many of you.
There is
we see a lot of thyroiditis, and I do only one thing, is ESR.
Okay.
And if I see ESR is more than 100, and if I see this is painful thyroiditis, otherwise I do a TMA TRC if they are positive. So these are my 2 criteria. Whenever I suspect, and if my suspicion criteria is do a T3, T4, TSH, and if you are confused with hypo or hyper, it is thyroiditis.
Yeah.
That means TSH is also low, T3 is also low.
Then it is.
TSH shows you hyper, T3 low shows you hypo. You said this is hypo or hyper, it is thyroiditis. That's a clinical tip we follow, and then thyroiditis, whenever there is a thyroiditis, always look for an underlying systemic, that they may be having an underlying systemic.
They may be associated, not to me.
No. PU as a diagnosis of.
But I would like to add to the indicators, clinical indicators, dryness. Dryness of eye is very important. Females coming with generalized body aches and pains and fatigue. So ask, because it may lead you to detect Sjogren's.
So Sjogren is a later part of the disease, but then dryness of eyes, and you'll find a lot of people, they will say this dryness is because of computer, it may not be. Don't link it to the computer, and there will be people all the 2 hours they are using eye drops to take away their dryness. Dryness may be a marker of autoimmune disorder all the time, and that dryness should not be ignored. If there is a dryness, what to do apart from putting in the...
So we look for other markers, of course. We look for any markers.
No, if I just want to take systematic, suppose that dryness is so common. If it is non-autoimmune dryness, because of the computer, I'm just trying to say, because how to treat dryness apart from the teardrops? There are some
cholinergic agents. We have Pilomax we have that we can use. But if we try it for 15 days, or if it helps, we can use it.
Okay. So apart from dryness, we come back to, is PUO a differential diagnosis of autoimmune?
Yeah, one.
Which, how? Right, what level we go for?
So when we find there are some other markers, like if you find that there are some leads to these connective tissue diseases, then of course there is no point prolonging it. But if we find that there are no clues and the acute phase markers are very high, and you find extensive investigation, some lung lesions or maybe some renal involvement, then it could lead to vasculitis.
So vasculitis will come into differential diagnosis of PUO. So let me go back to more clues to the GPS. When I talk about acute phase reactants, best is ESR. So remember that many technicians, what they do is to save time, they do it for 15 minutes, multiply it by 4, and that's wrong. That's criminal activity on the part of them to do that. 1 hour, Vestogen, ESR, and it is a prognostic and it is a marker of acute phase reaction. Second is CRP. Quantitative CRP. Obviously, CRP positive means more than 6. Less than 6 is a high sensitivity CRP. So CRP will always be more than 6. That's a screening test. You can do it for 8 rupees. But when you do a quantitative, it costs money. So do a quantitative CRP to find out the levels of CRP, which will help you later. And then what about C3 and C4?
C3, C4, if we find that there are clues towards lupus, if there are some skin lesions, some clues are there, and we find ANA positivity, we will do C3, C4. But C3, C4 of course will be reduced in lupus, but they can be reduced in septicemia also. So there procalcitonin and CRP help to differentiate. So if C3, C4 are low, ESR is high.
Okay. What about ferritin as an acute phase reactant?
Ferritin is an acute phase
reactant. Do we do it or we don't need it?
We do it only when we are not able to make out anything for adult onset Still's disease.
So my first is do a ESR and CRP.
Yeah.
Okay. And then we go back to the next step is
the markers.
ANA.
Yeah.
Which ANA we do?
ANA by
we do it by what we do?
We do ANA by immunofluorescence, indirect immunofluorescence.
So
that is the most specific.
What do I write?
So ANA by IIF by indirect immunofluorescence.
So that's the test we ask for it. When do we ask for dsDNA?
dsDNA if it comes positive.
If ANA is positive.
Then we go in for dsDNA and other extractable nuclear antibodies.
Like?
They have a long list, SSA, SSB, we have all of them, SCL70, polymerase, anti-aromatic. There's a long list of specific antigens.
We normally leave it at dsDNA.
So dsDNA and extractable.
So if ANA is positive, then what will happen to dsDNA?
That may or may not be positive.
If dsDNA is negative, ANA is positive, then?
Yeah, then still it can be lupus. So dsDNA we give importance. Of course, it is much more specific to lupus, but the importance we give is the renal and the cerebral involvement. So it also has been shown to go with activity of disease.
So I would say that if you find a patient, suspect a patient with ANA positive, refer it to a rheumatologist, or you do a dsDNA if a dsDNA is also positive. Don't handle. Go to a rheumatologist, take directions, and ask them how to follow such cases, because therefore for that, don't use your brain, use their brain, carry on, do surrogacy, commercial surrogacy is banned, but do this type of a surrogacy, hire their brain and treat the patient. Spending time and learn more about chikungunya, which is rampant, because you are going to get not more than, maximum you are going to get in your life is 15 or 20 patients.
Yeah, important thing I like to add that you find a patient like this, some little clues are there of lupus, but the counts are low. That also is very important. Leukopenia is one of the important markers.
So low TLC is a bad marker. It's a sign of active lupus.
It is, one manifestation. It's a hematological manifestation of...
So quickly about scleroderma, I might have seen not more than 2 patients in 30 years. So this is SLE, yes. We do see scleroderma, then undifferentiated and mixed connective tissue disorder. In total, I might have seen 5. If I might have seen 5, that means it's not that a common disorder, but yes, are there any clues?
So clue for this is skin tightening, especially over the hands, sclerodectally.
That's much
Face,
later, earlier.
The face, no, it starts, the swelling. The important thing is to find out any swelling, bogginess of the fingers, and Raynaud's, accompanied by Raynaud's.
So Raynaud's. So if there is a Raynaud's
Raynaud's
phenomena, don't look, send it to them. Get investigated. Whether it is cryoglobulinemia, whether it is anything, get investigated. Now we used to do one simple test. What we used to do was, we used to take away the serum and patient serum, and we used to keep it in the fridge for 48 hours. And we used to see precipitation of any cryoglobulins. Is that still valid?
Yeah, that is cryoglobulinemia.
We learned a lot of Jugadu medicine, and this
Yeah.
used to be one of them.
So then that is cryoglobulinemia, and that can come in gamma globulinemia, and one of the viral viruses which can cause is hepatitis C virus. But in Sjogren's, it is very common. We can see cryoglobulinemia. Of course, in laboratory it is very difficult. I have never seen globulins coming positive.
I have. So we used to do it. What we used to do was, we used to do it in every case of suspected.
Okay.
And we used to do it ourselves. So we used to get a lot of positive cases. Cryoglobulinemia. And that's how we clot retraction, cryoglobulinemia, ESR. This used to be our routine. We used to do it. And then we used to diagnose a lot of lipid disorders. You take a plasma, keep it there. And if the creamy layer comes, we know that this is hyperlipidemia. So we used to do a lot of clot retraction tests that used to tell us lots of hematological emergencies. We never used to do.
Probably we learned.
We never used to do CBC. CBC was banned in our hospital. Only peripheral smear. Only peripheral smear. Multiply the WBC by 2000 is the TLC. Okay. If the platelets are present in clumps, the platelet count is more than 1 lakh. And then check for malaria, the no parasites seen, no microfilaria seen. And then if microcytic hypochromic anemia, you should be able to diagnose. So peripheral smear, you should be able to diagnose everything. And if peripheral smear, if you see something, then go for testing. Otherwise, it was a crime ordering for any test. Similarly, in urine, if albumin is positive and sugar is negative, then go for blood sugar. And if albumin is negative and if it is urine sugar is negative, then no need.
That's how I think we were.
That's how we were. I mean, we were talking about. We were taught how when there were no investigations available. This is how we used to.
And I think you would have much better understanding.
We used to do sulfur salicylic acid solution. It used to cost us 1 rupee for 1 month, and then we used to do the sulfur salicylic acid.
A kind of arthritis with an acute presentation. It can have acute. It can have a later phase, which is called chronic tophaceous gout. The important thing about is that it is it can present as a medical emergency, and the most common joint involvement is the first MTP joint, which we call as podacta. So this is a very clear-cut presentation, and the treatment is NSAIDs from the very beginning, and later on we can add drugs to reduce uric acid. But what we find in our practice, that uric acid, whenever uric acid is there, or little high uric acid, so it is labeled as gout, and the treatment is started xyloric, 300 milligrams started. So it is important to understand that disease caused by uric acid or hyperuricemia is gout, and that presents as acute gout or chronic tophaceous gout. There has to be arthritis along with that. And the gold standard to diagnose is to take out fluid from the joint and demonstrate crystals. That only can diagnose gout.
It's a marker of early CKD in diabetic and hypertensive. If you get high uric acid, this may be a marker of hyperinsulinemia. This may be a marker of insulin resistance. And with symptomatic, you take away chili, chawal, maida, refined carbs. If you take away, the uric acid will go down.
Sure.
So unless the uric acid is more than 10, or if it is more than 8 and patient is symptomatic, then only consider about gout. Otherwise, it may be.
If patient is symptomatic, then we will definitely treat.
Yes, if the patient is symptomatic, then forget about the uric acid.
But the regular pains and aches would not make it gout. If there is arthritis, then it is.
And then in women, be cautious that the gout is relatively uncommon.
It is.
relatively
We
uncommon
don't
in
take
women.
that it does not.
And definitely in CKD, I do give Fabutas, I do give
Yeah.
the safer medicines to reduce the uric acid, because we have seen that if you reduce the uric acid, the burden to the kidney reduces. I don't know how correct it is, but we do give that. A little bit more on rheumatoid factor.
So rheumatoid factor is an immunoglobulin to the Fc portion of our routine immunoglobulin. So that is an autoantibody, and it has been seen that it is present in the normal population. Of course, its percentage increases with age. It can be present in 5% of population, in 40 to 60 years of people. But when it is there along with some disease, then we take it important, as the sensitivity of rheumatoid factor for rheumatoid arthritis, I would say, as 60-70%, but specificity is 80-85%.
Okay, quickly, we have now, how much time is left? I think we have around 5 to 10 minutes left. Let's quickly have rheumatic arthritis. Rheumatic arthritis. A, poly. It can have multiple joints.
It can have
Non-deforming.
non-deforming,
Migratory.
fleeting.
That between stages, it will, in one joint it will be different stage, another joint will be different stage. Young child, male
Less
or
than
female.
12. Yeah.
Less
take
than
it
12, male or female. It can be more than 12 if it is second time if it is coming.
Okay.
Second time as a relapse if it is coming. Non-deforming, seronegative. Non-deforming
Non-deforming.
and seronegative. It will never be that. That's one. Two. Now let's come back to rheumatoid arthritis. Women, deforming,
in
poly,
polyarthritis.
small joint, peripheral,
With extraarticular features.
seropositive, systemic manifestations. We have inflammatory spondyloarthritis. Patient will present with again
Buttock pain or
buttock
inflammatory
pain,
back pain.
inflammatory heel pain, improves on exercise, seronegative, plus minus
And improves with
HLA-B27
NSAIDs.
positive, improves with NSAID, improves with exercise. Okay, that's the third one. The fourth one is that if you have a psoriasis, if a patient has psoriasis, if he comes with the arthritis, then again it will be seronegative, poly or posse. That means posse means 2 to 5 joints, poly means 5 or more than 5 joints. And if you have a patient with that, you look for a psoriatic arthritis with that. Goodbye.